Allie, I would love you to do a little introduction of yourself before we get going, if that works for you.
That sounds good. I think I have to, consent. Okay. Are we ready?
Yeah, why don't we go ahead?
Yeah, well, thank you so much for having me. Focus is such an excellent resource, and I'm so really honored to be here today. So my name is Allie Matarasso. I am the dietitian in the Gyn clinic at UC Health. So I cover basically any patient with GYN cancer that comes in through UC Health at the Anschutz campus, and also doing some virtual coverage of the Highlands Ranch campus as well. So I've been a dietitian for a little over 7 years now. I've been with UC Health for about 2 years since moving to Colorado, and was previously working inpatient at a couple hospitals in New York City. So glad to be in Colorado, glad to be here with you today, and I hope you get a lot out of the presentation. And like Patrice mentioned, I'm going to stop about halfway through for questions, and then again at the end. But if something really urgent, yeah, just let me know. It can be pretty open. All right, so I think we can advance to the next slide. Thanks for doing this.
Yeah, I'm sorry, I'm hitting next slide and it's not going.
There we go. So just a disclosure that this is intended as a support service and educational format. It doesn't establish like a patient-provider relationship, and is not meant to provide patient-specific clinical direction, although this will be pretty specific, for GYN cancer, which is great. Again, but it is more generalized. So we do recommend a personalized consult with an oncology dietitian if your cancer center has that available. Here at UC Health, we do in our clinics, but if you are at a different cancer center, you can ask your team if there is an oncology dietitian on staff, or if not, if they have any recommendations for someone in the community. And at the end, I can give a resource for that if someone would like. Okay, do next.
Ready for next slide?
Yes, thanks.
And can I just remind everybody, please mute, even if you think you're being quiet. Little rustling and stuff like that does affect the conversation. And Allie, I wouldn't mind if you were a tiny bit closer to the microphone. You could be a little bit louder.
Okay, I can't physically get closer, but I can speak louder.
Okay.
That works.
Thanks. Here we go.
Great. I'll get as close as I can. Yeah, so the next slide, please.
Yes. Which I hit, and it is not advancing. For Pete's sake. Sorry, everybody. Don't know what's going on here. Ugh.
Yeah, it works.
Well, you know what I think I'm going to do is go ahead. I'm going to stop sharing since this isn't working on my side, and go ahead and make you host.
Okay.
Shoot. Ask people who are waiting to come on in. All right.
What if it wasn't in the present mode and it was just like those slides that you had up beforehand?
It's always, that's the way it always works. That but I can do it by hand, which is less elegant, but everybody could hopefully see.
Yeah.
So we'll do that.
Okay. Yeah, that's what I meant. It's all right. There we
Okay,
go.
sorry about that, Allie. Okay, we'll get going now.
That's fine. Okay. So just the objectives that we're going to cover today, we're going to review nutrition recommendations during cancer treatment itself. So during what we call active treatment, we're going to identify the most common side effects of treatment and also common what we call disease-related nutrition impact symptoms. So things that affect our nutrition related to the cancer itself, in addition to the side effects that treatment might cause. We're going to learn how to apply strategies to manage these side effects and also those nutrition impact symptoms of cancer itself. We're also going to take some time to review what I like to call hot topics, such as alternative diets, fasting, and dietary supplements. And then we'll review some post-treatment nutrition recommendations after treatment's over, kind of how to go from there diet-wise. Okay, next, please. So nutrition goals during treatment. There's 3 main goals, and if you worked with me, you've definitely heard this a lot. And it's basically want to maintain your current body weight. And that applies whether you are overweight or obese or have been told to lose weight before. It doesn't matter. We want to maintain as much as possible during treatment, and we'll talk about why. Eating enough protein and then drinking enough fluids. Those are kind of our 3 overlying goals during active treatment. So maintain weight. Research shows, the studies show that when people maintain their weight during treatment and get enough calories and protein, there's less treatment side effects, and they tend to tolerate the treatment better, whether it's chemo, radiation. So that's why we want to maintain your weight. If you've lost weight before, it's not like you have to put it back on, but we try to want to hang out where you are. Again, not an alarming if you go down a pound or 2, but we're trying to avoid quick, rapid weight loss during treatment, because that leads to more treatment side effects and loss of muscle. So we're going to go through this a bunch. These interventions are throughout this presentation, but basically some strategies to maintain your weight are going to be to eat smaller meals more often. So a lot of us come from the whole breakfast, lunch, dinner, clean your plate type of mindset, but that tends to not be as well tolerated. So a smaller meal, which we might consider a snack, like cheese and crackers or some yogurt and nuts, more often. If you're not hungry, and we'll talk about appetite later, a lot of people find it helpful to kind of eat on a schedule instead of waiting to be hungry. So trying to set an alarm for every 2 or 3 hours, or a kitchen timer, or even have in your head, okay, 9, 12, 3, things like that, just to help stay on schedule. It helps from getting behind and then catching up later. Okay. We're going to talk about this more again, but using fluids that have calories and protein may be better tolerated at times of low appetite or nausea instead of eating food. So we can get excellent nutrition from oral nutrition supplements, which are things like Ensure, Boost, Orgain, or homemade smoothies with protein powder or yogurt, milkshakes, and we can, customize those as well. Or you can buy the pre-bought ones, which are also nice. And this last bullet point is something I just want to take some time is we might, during treatment, you might need to kind of rethink healthy eating as we know it. So we might think healthy eating is less meat, more fruits and veggies, whole grains, not drinking calorie-containing fluids. That just might need to be reframed a bit during treatment when we're pushing calories and protein. Sometimes I'll say, we can put the vegetables aside for now and focus on the starch and the protein first. And then if you're still hungry, go to the vegetable, which might be a different mindset than normal. And that's because if you are having side effects of treatment, like low appetite, taste changes, nausea, or you're getting full quickly, things like that, you might not have enough room for all of those foods. And we want to kind of get the most bang for our buck in terms of getting those high calorie, high protein foods in first. So this might not be a statement that applies to everyone, but just trying to go into treatment with the mindset of, I might need to just kind of rethink how I'm eating for the next X amount of months of treatment. Okay, because what's healthy for me right now is getting enough calories to maintain my weight, limit my side effects, and kind of get through this, and then revisiting later. If that makes sense. So just kind of a nice a nice mindset to be in. Food preferences might change during treatment, and that's okay. So just trying to go with the flow. Is that liberalizing within your comfort zone? And we'll talk about more as we go. I'm gonna hit next for now. Thanks. So protein, really important in general, also during treatment. A lot of times you'll hear about your blood counts when you come in, making sure, you get labs before your treatment, making sure you're safe to get chemo. Protein helps rebuild those cells between chemo cycles. So when you're due for the next one, protein helps rebuild that. Okay, so important for cell growth and repair. It's also an important part of our immune system by helping replenish those T cells, and it supports your lean body mass, so strength and fighting fatigue that's just inherently associated with treatment. So like I just said, preventing muscle breakdown and muscle loss, faster healing and recovery, especially if you've had surgery either before or during your chemo cycles. Protein's really important to help heal from that. And like I said, helping maintain your healthy T cell count by fighting off infection. So we can go to the next slide. Great. So how do we increase protein intake? We don't typically focus on grams of protein or ounces because that tends to be a burden. You basically want to look at your meal and your snack and say, is there a source of protein here? Okay, so trying to include a source of protein with every meal and snack. That can be red meat, beef, lamb, bison, veal, things like that. It can be poultry, like chicken and turkey. It can be fish. It can also be eggs. And then some things we might forget are protein, like beans and lentils and legumes and soy, tofu, soy milk, edamame, nuts and nut butters like peanut butter, almond butter, also dairy, milk, cheese, yogurt, ice cream. So whatever sounds good to you and you tolerate best, just making sure there's some type of protein there. But you don't have to feel like, oh, it needs to be a piece of meat on a plate. Maybe that doesn't sound good, and that's okay. There's plenty of other options. And also those supplement shakes or making your own also count as protein. So if you are feeling fatigued, maybe you go to more convenience type items like a yogurt or a cheese stick or a handful of nuts or a spoonful of peanut butter that don't require much meal prep. Okay, or drinking a homemade shake or a store-bought shake. Adding milk to things like oatmeal can turn like a nice starchy item into a higher protein dish. So trying ways to sneak it in, but knowing that it doesn't have to be traditional like meat as a protein source is totally fine. Whatever works best for you and your food preferences and what you're tolerating.
Next slide.
Yes, please. The next part is drinking plenty of fluids. This helps remove waste from your body. It also helps get that drug out after chemo. It helps you avoid dehydration, which dehydration can often contribute to fatigue or sometimes standing up and being a little bit dizzy. It helps support your kidney function, which is important because some of these chemo drugs can be a little bit tough on the kidneys. So making sure you're adequately hydrating to keep the kidneys healthy. Also, dehydration can either cause or worsen side effects like nausea, dry mouth, certainly constipation, and muscle fatigue. So we want to be able to drink enough fluid throughout treatment. You can hit the next slide. So typically what our recommendation for fluid is just that of the general population, which is 64 to 80 ounces of fluid per day. And this can be any decaf fluid. I think sometimes we get stuck on water, but maybe water doesn't taste good, or maybe you're bored of water and you want something else. So juices or a splash of juice or fruit in your water, or things like milk and broth and Jello and popsicles. Those all what we count towards hydration. So if you need to switch it up in terms of what you need to stay hydrated, that's more than fine. Or using those little droppers, that's okay. Even those nutrition shakes, even those like thick, like Ensure Plus, those are pretty much 76-75% water. So just rethinking hydration if water is not your thing. But unless your doctor tells you that you have a different fluid requirement, which could be the case, it's 64 to 80 ounces of decaf fluid per day. And I often get the question of if you can still have caffeine, and yes, you can. I don't mess with coffee, and that's something that we tend to have for decades, how we drink our coffee. No reason to avoid it. We just don't count caffeinated beverages towards the 64 to 80 ounces. Okay, can hit next. So just some tips on how to make nutrition easier during active treatment. Again, this might look different than what we typically think of as our healthy diet, but I would never want someone to not eat because they want to avoid eating something frozen, but they don't feel up to preparing something. So a lot of this is convenience type foods like pre-mixed drinks or frozen TV dinners, or you can get a wide variety. And then if you're not in the mood for one day, that's fine. It just kind of hangs out in the freezer. Nuts or trail mixes or nut butters, using instant oatmeal packets. You don't have to stand at the stove and cook like steel cut oats for a long time. String cheeses or those little Baby Bell cheeses, peanut butter crackers, yogurt, protein bars, hummus with pita bread or pretzels or chopped veggies. So things that require little to no prep are nice to have on hand, especially if you know, okay, days 3 through 10 are really hard for me. I'm fatigued. Having things on hand like during those days. If you have days that you feel better, like maybe that 3rd week before coming in for treatment again, and you're up to cooking and you enjoy it, that's a nice day to kind of cook extra and freeze the extra portions, maybe even in individual containers that you have food you like for those tougher days where meal prepping isn't realistic. Okay. Also asking family and friends to help cook and prepare meals. And don't be afraid to give them guidance in terms of foods you can or cannot tolerate. People are there to help you and they want to help. And they probably welcome some guidance. I'm not doing so great with meat these days, but a lasagna that has some cheese in it would be really helpful for me. Or a baked macaroni and cheese or a chicken noodle soup. That way you have, when they're helping you, that way it's something that actually will make meal prep and eating easier for you. And then keeping non-perishable snacks within reach when you feel like eating. So maybe if you're hanging out on the couch, you're really fatigued, having non-perishable things next to you so that you can have it when you're ready to eat, like those peanut butter crackers or granola bars or things like that, just so they're readily available. Okay, next, please. So now we're going to go through some nutrition impact systems of having ovarian or a GYN cancer itself. These are feelings or symptoms that you have not from chemo, but from the actual cancer. So they're a bit different, and they just have different management. So we're going to go through those in addition to later going through the typical chemo side effects. Okay, so you can hit next. So malnutrition, and I put this on here because it's pretty significant, the percentage of individuals that present with malnutrition at time of ovarian cancer diagnosis. It's seen in up to 70% of patients because of those symptoms that prompt visits, like early fullness, lack of appetite, or you feel like you're gaining weight in the abdomen and you're not hungry, but you might be losing like true muscle other places. So malnutrition is extremely common at time of ovarian cancer diagnosis. And there's studies that have looked at survival in advanced ovarian cancer and shows that when we lose weight during chemo, it's an indication of poorer survival. So that's why we push calories and push protein during treatment, because there's ways we can combat this. Nutrition is something that we can manage with the help of your team and your dietitian, your doctor, and your support. So it's just important because if you present with malnutrition and then start treatment, we want to intervene as early as possible with our nutrition recommendations. Okay, so some interventions for this, and this is a lot of what we just went over, is avoiding restrictive diets during treatment. I always say liberalize within your comfort zone. So maybe if you typically don't eat added sugar and you don't feel comfortable eating a ton of added sugar, maybe on days that eating is really hard, you feel comfortable having a piece of cake or something that sounds attractive to you, because you know that that's going to help you get your calories to support your weight build your blood counts back up and tolerate treatment better. Okay. Monitoring for changes in appetite and intake and intervening as soon as possible. You know, I like to talk to people in the beginning of treatment so we can say, here are some tools in your toolbox. Look out. Sometimes this happens. Look out for, oops, I skipped lunch 2 days in a row. I don't usually do that. Then you can set a reminder so you're not behind several days and weeks of lower calorie intake. Oh, I usually eat a full sandwich and I ate half. Noticing that change, that's okay. But let me try to eat the other half 2 hours later. So just getting ahead of it is super, super helpful. Adding liquid calories, again, shakes, smoothies that have protein, pre-made oral nutrition supplements. Making sure that there's a protein source at every meal and snack, which we talked about, whether it's plant-based or animal-based. Adding fat, if well tolerated. So fat's the best bang for our buck in terms of calories. So adding olive oil to a food adds more calories without having to eat a larger portion. So sneaking in things like that, cheese or avocado or cream or butter or oil, again, might not sound typically healthy, but healthy for you right now. Getting calories in is hard. If getting calories in isn't hard, then you don't have to do these things. So adding fat if well tolerated, maybe you typically eat fat-free yogurt, but you're getting full quickly, so you can't really eat beyond that. But switching to a full fat yogurt, same size, 5 ounces or whatever it is, but more calories without having to eat a larger portion. So things like that. And then if you are having surgery and you know you're going into surgery, optimizing your nutritional status beforehand. So being well nourished going into surgery has excellent outcomes in terms of lowering infection risk, shorter length of stay in the hospital, faster wound healing. So if you know you're going into surgery and you're eating well, maybe you add a nutrition shake once a day to help further optimize it. Or if you're not eating well, you implement these tips even before starting treatment, but going into surgery. All right, and hit next. So this is something extremely common, which you may have experienced, is early satiety, AKA getting full faster. Oh, I take a few bites and I get full. I don't feel like I have a lot of space to eat. So this can be because of in the setting of ascites, which is fluid in the abdomen, or if there's any cancer in the abdomen, in the bowel, or in the peritoneum, which is the lining of the abdomen. It could be because you're constipated. You know, if you're pretty constipated, you might get full quickly. And also if you're on pain meds tend to slow things down in terms of how we digest food. So you might feel like you're getting this fullness feeling when you're on pain meds. So again, a lot of the same interventions, eating every 2 or 3 hours, smaller amounts instead of 3 larger meals. This is a big one, which seems simple, but it's helpful, is trying not to eat and drink at the same time. If you feel like you have limited capacity for food, if you drink a glass of water right before or during your meal, that's going to take up space and there's going to be less space for food bites. So something that people find helpful is, I'm going to eat in 20 minutes. I'm going to stop drinking to allow some space to open for food. Maybe I can get a few more bites in. And then of course, if you need to drink during your meal, taking a few sips, that's fine. But we're talking about when you're kind of trying to get that hydration in, trying to separate it from mealtime so you can optimize your hydration and optimize your food separately throughout the day. That might take some practice, but you might realize, oops, I'm not hungry. I just drank some fluid. That's fine. Just wait a bit and then try. Okay. If you're very full, but you know you need to eat, that's where the liquid shakes might come in. So say you're like, all right, it's 2 p.m. It's time for me to eat. I don't want to eat anything, which is common. But maybe I can sip on this smoothie or this Ensure Plus for the next 30 or 45 minutes and get 360 calories, which is similar or bigger than the snack you might have had. That might be better tolerated. And that's fine. You might need more of those on certain days and less of those on other days, but we can use those as food. Okay. Taking bites and sips between meals. So maybe you stroll by the kitchen and you take a little spoonful of peanut butter or a bite of cheese or you go into the fridge, and every time you go into the fridge for something for you or your family, you take a sip of an Ensure. That all adds up throughout the day. It's not like it's better or worse to do it all at one time or separate. It all adds up. So whatever way feels best is the way we want to go without forcing. I said this before, but consuming your protein and your starch first to get your protein, your calories, and the vegetable last. Or if you really want veggies, if we can load them up with dressing or oil to make them more caloric, that's a great way to have a happy medium between the two. Same thing, adding fat if well tolerated. So these are some tips that can help make eating easier if you are having that fullness feeling in the abdomen or even higher. Okay, hit next. So this is a big one. I'm sorry if the next slides are busy. I'll go through them in a way that hopefully works well. So constipation is super common, either at diagnosis or randomly throughout treatment, and it can vary significantly in how severe it is. Maybe you have constipation induced by pain medication or anti-nausea meds like Zofran, or the IV versions of the anti-nausea meds that you might get on your chemo day, where you might be constipated for 3 to 5 days after treatment. So those are examples of when you might be constipated, or you might have a more chronic constipation if there is cancer or disease in the bowel or the peritoneum, again, that lining of the abdomen. So the reasons vary. I also wanted to go through quickly some obstructive type symptoms just to keep an eye on. If you're having these, it's important to talk to your doctor, and then I'm going to give you the nutrition tips for how to eat to lessen those symptoms or to not exacerbate them. So mild obstructive symptoms are maybe some like occasional abdominal cramping, some excess gas, bloating, and it's just hard. You just want to talk to your doctor about it because you might be bloated because you have fluid in the abdomen. It might not be because of this. So just keeping an eye on this, but always talking to your doctor about why it might be. Moderate obstructive symptoms would be when you get more pain. So you still have the cramping, but now you might have abdominal pain, bloating that doesn't seem to go away. And then severe would be severe abdominal pain, maybe vomiting, heartburn, significant bloating and cramping. That's definitely when you want to chat with your doctor. Okay, so how do we manage this with food? If you are constipated, it's important to discuss an individualized bowel regimen with your oncologist. So this might be maybe on days, right, starting a chemo and a few days after, you might need to take Senecot or Miralax or some type of laxative to help get you through those days, and then you might be fine the rest of it. Or you might need to be on a more chronic bowel regimen. Maybe you have a combination of a stool softener and drugs. So speaking with your oncologist and the pharmacist can really help manage constipation. So a low fiber diet may be recommended. And I want to take a while to spend some time on this because typically we think constipation increased fiber to have more regular bowel movements. If you Google constipation, that's going to be the first thing that comes up, but that might not be appropriate. And the reason that might not be appropriate is because if your constipation is induced by pain medication, anti-nausea medication, or disease in the bowel or the peritoneum, adding more fiber might just make you feel more bloated and full and uncomfortable and might not actually produce a bowel movement. So it might depend on the person. Adding fiber might work for you, but oftentimes we actually recommend a low fiber diet so you feel less bloated, feel more comfortable, paired with like the use of a Senna or a Miralax or a laxative. Okay, and we'll go through what the low fiber diet means in the next couple of slides. And again, it might be individualized. You might tolerate fiber okay, but a low fiber diet might actually make you feel much better. Okay, so chewing foods well helps just kind of start the breakdown of digestion early. We talked about aiming for 64 to 80 ounces of fluid per day. That also helps digestion and peristalsis and things moving through the GI tract. Eating as much as you feel comfortable without forcing food. That's a big thing. Honestly, sometimes eating might feel forced in general, like you're eating when you don't want to eat, but I'm talking about like really don't feel well, nauseous, and then pushing food. We don't want to do that. Okay. If you are having gas or bloating, it's helpful sometimes to avoid carbonated beverages because of all the little bubbles. You might be fine if you just let it go flat a bit. Chewing gum, because that just brings in a lot of air. So if you're feeling bloated, that might contribute, and drinking through a straw also brings in air. However, sometimes people find they can get more fluid in with drinking through a straw. So just monitoring and seeing if that's helpful or not. But again, this is not a one size fits all approach to management. So it's important to talk to your dietitian and your doctor about what's the best combination of bowel regimen, diet, fluid for you. Okay. You can hit next. Okay, so if you have mild obstructive symptoms, or if you're constipated and adding fiber makes you feel worse, we recommend a low fiber diet. And this is low in insoluble fiber. Insoluble fiber is basically the indigestible part of food, which is like skins and seeds. So the skin on an apple or seeds in a strawberry. Those things are typically adding bulk to our stool, but if things, again, aren't moving through how they should, adding bulk might make you feel not so great if things aren't actually eliminating from the body. So people might tolerate things like well-cooked soft vegetables without skins and seeds as opposed to a salad. So cooked green beans or cooked spinach. Spinach breaks down very nicely as opposed to like something like kale or cabbage. Cooked carrots, cooked root vegetables. You can always take the seeds out of things if you needed to, like for summer squash. Vegetables that are in stews and soups are like super soft. A pureed tomato sauce would be fine. So there's still ways to get in veggies on a low fiber diet, and even green vegetables. They just might feel better to eat them in this form as opposed to raw vegetables, or even things like Brussels sprouts that are cooked but just are really tough. Corn, peas. An avocado is unfortunately high in fiber. However, if it's blended or because it's so soft, some people might be fine with it. And I'm going to go through the rest of the food groups, but this isn't like an all or nothing list. If you do better with cooked vegetables, but you tolerate avocado fine, there's no reason to avoid it. The goal is to be on the least restrictive diet possible. Okay. So fruit, people might feel better eating things like melons, like cantaloupe, honeydew, watermelon, peaches and pears that are peeled, or mandarin oranges instead of berries, or kiwi that have all those little seeds in them, or dried fruit. Okay. White starches might be better tolerated than brown or whole grains. So white rice or pasta, potato without the skin, sweet or white is fine. Lower fiber cereals like Rice Chex, Cheerios, Rice Krispies. And oatmeal is actually totally fine, even though it's fiber, it's soluble fiber. So oatmeal tends to be well tolerated if that's something you really like. And then we get into our protein. So dairy's fine, unless you're lactose intolerant, you buy the lactose-free brands. Things like meat, as long as it's really tender, is fine. All fish and seafood are fine. However, beans are really high in fiber. People tend to tolerate things like well pureed hummus because it's really smooth, or refried beans because the skins are removed, or smooth creamy peanut butter instead of actual nuts. So in that, it's just like the texture thing. The smoother ones might just be better tolerated. And then again, sweet snacks, those things are all fine as long as they didn't have like hard nuts and seeds and dried fruit. Also, popcorn tends to be pretty difficult if you are having these obstructive type symptoms. So again, not a all or nothing or everyone recommendation, but something that might help. You also might only be recommended to be on this diet for a short period of time, maybe 4 to 6 weeks after a surgery that involved a bowel resection. Then you might be given okay by the healthcare team to eat a regular diet, and then you'll just kind of add these foods that you've been avoiding back in one at a time and just see how you do, and just see if there's something that works and something that doesn't. Okay. Hit next.
Ooh.
Yeah, next slide.
It's doing it again. Guess we'll go back.
It worked for a while.
I know. For Pete's sake. Sorry, everybody. I'm going to have to stop sharing the screen for a second. There we go. Okay, we back?
Yep. And I think there's just one more slide till we take a break. So that was for mild symptoms. The next one is for more moderate symptoms where you basically want to go lower on the fiber. So a lot of the food groups are the same, but instead of cooked vegetables, you'd want to just do pretty much like pureed soups. Small amount of tomato sauce might be fine. You can do vegetable juices, something like V8, as long as it was without pulp. Same with fruit. We'd go to fruit drinks or strained fruit juices without pulp. And then for meat and poultry, all should be fine, but maybe that casing on like a sausage or like a processed meat might be tough to digest. So doing just more like tender chicken, fish, beef in like kind of like just like a well-cooked way that's not super tough. And then the last part is if you are having severe symptoms, you might tolerate a liquid diet better. Again, if you are having severe symptoms of any kind, of course you want to contact your doctor, but this is pretty much avoiding solid food and doing little to no fiber food. This is a short term, just it might get you through, or in the meantime, until you can get in touch with your doctor. But you can still meet your calorie and your protein needs on a liquid diet with supplement shakes, with smoothies, with milkshakes, with things like cream of wheat cereal, pureed soups, especially cream soups like bisques or things with coconut milk to add calories, ice creams and puddings and popsicles, things like that. So even though it's liquid, it can still be kind of what we call a full liquid diet to get the calories and protein you need in the meantime until those symptoms subside. All right. So I think the next slide is a break. I know we went through a lot of stuff. If anybody has any questions about what we've talked about so far.
Feel free to unmute yourself if you have a question.
I have a question. Can you hear me?
Yes.
Oh, good. I have a question. So, have you read the book, The Macrobiotic Approach to Cancer by Naisha Winters? Or the Metabolic Approach to Cancer by Naisha Winters?
I haven't read it.
Okay, because she has this huge following in Colorado. She's from Durango. She's a naturopath.
Yeah.
And basically, the premise is avoid carbohydrates and sugar because that's what makes cancer grow.
Sure.
And so I'm sure you and your department have come across this, and I'm wondering what your take is on that.
Sure. I'm going to get there, but we can talk about that now. It's a great question. Sugar and cancer always comes up. Kind of the sugar feeds cancer, carbs feed cancer. So I can address that now, and then we can address it again later. So basically all carbs break down to glucose, which is the simplest form of carbohydrate. So all carbs, meaning whole grains, fruits, veggies, are also like candies and cakes and things like that. They'll all get there. They get there quicker from simple carbs, like juices and candies and things like that, and slower from complex carbs like whole grains and fruits and veggies and other starches, but they all get there. Glucose fuels all of the cells of our body, healthy cells, cancer cells, brain cells, things like that. some studies have shown that glucose will go more quickly to a cancer cell. However, they don't like preferentially fuel them over a healthy cell. However, further research shows that unfortunately, cancer cells can be very savvy and they can use pathways other than glucose to be fueled, like fat and protein and other metabolic pathways, even if you had a total carb/sugar elimination. So we practice evidence-based medicine here, so we do not recommend limiting starches for that reason, or carbohydrates, because there's not enough research to show that that is helpful. And also, especially during treatment, eliminating a whole food group will often lead to weight loss and potentially malnutrition, not tolerating the treatment that well. You know, if people want to do a diet like that after treatment, that's totally fine. Or even during treatment, we just kind of let you know the potential risks of doing it, of course, but it's nutrition is a personal decision. So I just like to provide the evidence-based research, and then of course you can make your own decision. But typically what we recommend is avoiding restrictive diets during treatment. And then after, and once you're done with treatment, we do recommend avoiding added sugars, but we don't recommend avoiding carbohydrates like starches, because they're a great form of, like our main source of energy for the body.
Right. So evidence, when you say there's no evidence-based research, has there been any research done? You know what I mean? You could have I don't know, but I'm assuming you can have no evidence-based research because no research has been done.
Yeah.
Or you could have research that was done and it proved that there was no significant advantage to going keto.
Sure. So I have some studies cited about keto later on in the presentation that we can go.
Okay, good.
Yeah, really good question. It comes up a ton, and it's a really important point to address. I'm also going to talk about short-term fasting around chemo. That is also kind of like a up and coming topic, kind of along the same lines.
I mean, personally, I'd much rather eat the way you're talking, the way I would normally eat. And so I've been struggling with this other concept of like, really, I can't eat quinoa. Really, I can't eat whole wheat. Really, I can't. So anyway, I'm done with my question, and I'll look for the rest of your talk.
No, it's an excellent question. And you're right, like quinoa is our only whole grain that has all of our essential amino acids for protein. There's a difference, right? Maybe eating quinoa and then eating a ton of cake, even though they're both carbohydrates. So
right.
A lot of people do struggle with that. And I think, we go on the research, and American Institute for Cancer Research is a great resource for this. There are always new studies coming out. I think, we would also pretty much know if there was like a specific diet like keto that would be a cure or like a adjunct to treatment. But so this is where we're at right now, but I think it's a really, really good question.
Okay, I'll wait to see those studies. All right, perfect. Okay.
Yeah. Any other questions? All right. Can always get them on.
I have a question.
Oh, sorry. Yeah.
I'm having, because of my surgery, I have.
Oops, Alyssa, you just got muted somehow.
Yeah.
Unmute, sorry. Just my hormones are all over the place, and my eating and my energy level, and I'm having a lot of insomnia. I don't know how to get on like the right path to nutrition, and like most mornings I'm not super hungry, and then I don't know. My appetite's all over the place. Like I cannot eat like a whole day, and then other days I just want to eat the whole entire day. And I don't know how to stabilize things like that.
Yeah, and that it's tough when it goes back and forth between the two. I think on those lower appetite days, trying to think like I still need to get my nutrition in, and maybe you use some of these strategies of like setting an alarm or using shakes on those days. And then on other days, sometimes it's hard when you're feeling totally ravenous, but trying to maybe do more like mindful eating approaches. Like I just had lunch. I had like a nice balanced meal with like protein and starch and vegetables, but now I'm feeling hungry again. It's like, okay, is there something else I can do to satisfy that? Or maybe I do need more. Your body might need more on those days, and that might be okay. It might just be kind of learning its new metabolism. I'm not sure how far out from surgery you are, but that might help just be a little bit more regular over time. In terms of insomnia, you can talk to your doctor. I know sometimes they'll recommend like melatonin here.
Yeah, that doesn't do anything. My doctor is now trying me on cortisol, but I'm afraid adding too much cortisol, does that make you gain weight? Or I don't know.
I'm not sure if it, in terms of the body, it can be a stress hormone, which might, but I'm not sure if it's how it is, if it would be taken in the form of a pill. But yeah, if you're concerned about that side effect, I would ask about that. I know sleep is something that's really tough. I'm not sure if maybe like meditation might be helpful.
Yeah.
What else?
I also had a question too. Sorry, I have like a lot of food sensitivities, not like allergies, but I'm not supposed to have soy and lots of other things that are in a lot of those pre-made shakes and meals and things like that. So I've just taken to, and I can't eat eggs either. So I want to get protein in the morning. So I've been eating a lot of just nuts. Like I'll just eat like a handful of nuts and be like, okay, there's breakfast. Okay, my next handful of nuts is lunch, like, and I don't know what to eat like throughout the day to have it be balanced, because I'm trying to like avoid the foods that they told me to avoid with my food sensitivities too. So
you tolerate dairy? You have dairy?
I'm not supposed to do, dairy, eggs,
Okay.
fish, seafood, and beef I'm supposed to avoid, but that's like the number one food that I crave. So I'm like, I can't give up everything,
And I don't know your exact case, but I agree. Any way you can liberalize within what they feel is okay. You can also do, what about coconut? Because you can do plant-based.
I love
That's called, there's a brand called Siggi's, SIGGI.
What's it called? Okay.
SIGGI.
Okay, yeah.
They have a coconut milk yogurt, but it's fortified with like pea protein. So it's very high protein, like 10 or 11 grams, unlike a lot of the other plant-based yogurts. So that's an option.
Okay.
Nut butters. I don't know if you can do lentils or hummus or things like that for protein. You can also do a plant-based protein powder. I have a recommendation that's like pea, hemp, and goji berry. If you can eat those things, I'm happy to give you guys the name if you'd like.
Oh yeah, that'd be great. Thank you.
So it's called Sun Warrior is the brand.
Okay, let me write this stuff down. Sun Warrior and Siggy.
And it's Warrior Blend is the type. Make sure to get
What did you say? What's the type?
Warrior Blend. It's like it's one of their products.
Okay.
Because the brown rice one tastes real bad. It's not. So the Warrior Blend, but that's one you can add to like nut milks or if you buy the natural flavor, which doesn't have stevia. I don't know if you don't mind stevia, but the flavored one stevia.
Yeah.
You can add natural flavor to soups. You can add them to baked goods. You can throw it in anywhere to add protein in a way that the taste will be hidden.
Okay.
And someone recommended too, like a chia pudding made with like a alternative milk is also a great option if you tolerate fibers with the chia seeds.
Okay.
You can maybe do a smoothie in the morning.
Thank you.
Yeah, of course. All right. Shall we continue?
Sure, because we know we have another Q&A coming. So
Yeah.
Here we go.
So now we'll talk about side effect management. So these are going to be side effects of chemoradiation, things like that. So I think this is really important, is always advocating for yourself side effects If things aren't feeling right, talk to your team. There's always something that can be done. So trying to identify signs early and symptoms early and speaking with your team as soon as they come up. Maybe that involves calling the clinic before your next visit, and that's okay. That's why they're there. So we want to be proactive instead of reactive. So I know here they'll prescribe some anti-nausea medications as needed before you even start treatment. So having those on hand, making sure you've gotten those from the pharmacy and know how to take them if you need them. It's better to address side effects as soon as they begin than trying to like catch it after. Just like we talked about with the constipation. Maybe you know that you get constipated right after chemo, so maybe the day of, the day before treatment, you start taking your laxative to get ahead of it, okay? Also, if things haven't worked, keep asking, keep bringing it up, because there's a ton of anti-nausea meds, there's a ton of laxatives, there's a ton of pain things. So not just having to sit with that feeling or side effect or whatever it is, making sure to bring it up to your team, or maybe there's a way to kind of alternate your anti-nausea meds to get the most benefit out of them. So the nurse and the like infusion nurses tend to be excellent at side effect management, pharmacists, the doctor, of course, the dietitians, the PAs. So always just asking and making sure that your side effects are as well managed as they can be. Okay, we can click next.
Oops, hold on one sec.
Okay,
Sorry.
perfect. So common nutrition related side effects, and these are really based off of kind of like a more standard like carbotaxol regimen. There might be other drugs that you may have been on or be on that have different side effects, but these are kind of the main ones that I typically see. And if you have questions about other ones, I can definitely try to answer them. So decreased appetite, taste changes, nausea, constipation, which we previously discussed, so I'm not going to go through that again, and then diarrhea. So you can click next. So decreased appetite, why does it happen? It could be the cancer itself, or it could definitely be treatment. Also, pain will also be a limiting factor for wanting to eat. Also, having stress or anxiety can either decrease our appetite or increase our appetite, but sometimes anticipation and anxiety can decrease appetite. Or maybe you have a decreased appetite because things taste different and that makes you not want to eat, or because you're constipated, or because you're nauseous. So some of these are kind of interrelated. Okay, do next, please. So again, things that we've talked about a bunch of times. Eating on a schedule rather than waiting to be hungry. Not super intuitive, but really helpful in getting your nutrition in a way that feels best. So eating 4 to 6 times a day instead of 3 square meals, eating on a schedule, setting an alarm, using those calorie containing fluids, either homemade or pre-made, and then making sure other side effects are addressed. So if taste changes are the reason you're not hungry, we need to attack that. Or if constipation is the reason you're not hungry because you're feeling full, getting on a bowel regimen. Nausea, managing those anti-nausea medications. Okay. Can click next. Taste changes, often common side effects of those platinum-based chemos. Also, if you have dry mouth or dental issues or dehydration can actually contribute as well. Oftentimes we'll see bland or like what I like to call like muted taste, like it just doesn't taste how it's supposed to. It's like a lesser version of that. Or you might have a metallic taste in your mouth, again, from like a platinum-based drug. Or sometimes things taste too salty or too sweet. One might be better than the other. Okay, click next. So how do we manage this? Because eating is not super fun if things don't taste good. So if you do have a metallic taste, using plastic utensils or bamboo or wood or basically non-metal utensils, things that are metal like utensils or canned items, or even those like these water bottles that have metal in them. If you have a metallic taste in your mouth, those things can exacerbate that. So using maybe like a plastic or a glass water bottle, again, switching away from metal utensils. Sometimes meat, like red meat, might also have a metallic taste to it. If that happens, getting protein from other sources, like plant-based protein products, dairy, eggs, or soy, or even chicken and turkey might be better than meat. So that's the deal with metallic taste. If things taste bland or muted or off, I always recommend rinsing with this baking soda salt rinse recipe that's on the bottom of the screen. I'll say it out loud in case people are on the phone. So it's 4 cups of water, 1 teaspoon of baking soda, and 3/4 of a teaspoon of salt. This would be used for the whole day. So right before you eat, you'd want to rinse out your mouth with this rinse. Don't swallow it. Just rinse your mouth out and then eat. It can basically help neutralize the acid in your mouth and like wake up the taste buds and make things taste better. You'd want to use this for the full day. You can use it several times a day and then make a new batch the next day. So if that's too much volume, because 4 cups is a lot, you can always cut it in half and do 2 cups of water with half a teaspoon each of baking soda and salt. But that's simple and it can be really helpful to use right before eating. This is actually the same rinse you would use if you did have any mouth sensitivity or mouth sores. Okay. Also, if foods taste bland or muted, sometimes tart or tangy flavors can help, like barbecue sauce, sweet and sour sauce, teriyaki sauce, things like that. Sometimes marinated foods taste better. Also things like pickles and olives or vinegar-based dressings, things like pineapple, things like that just like wake up the taste buds might taste good. You might also just kind of have to adjust the seasoning if things taste too salty. Maybe you take out your portion before other people add salt to theirs. This sounds very weird, but if things taste very salty, even adding a little bit of sugar to something might help counterbalance that. Or sometimes adding like a squeeze of citrus to something might help like wake up the flavors a bit. So sometimes it just takes some adjusting in seasonings, but these flavors tend to be attractive or appealing if things taste like super bland. Okay, you can click next. Oh, and you might have to, if sometimes water tastes off, you might have to use like some lemon in there or some fruit. Or I had one patient tell me she put a Jolly Rancher in her water because it gave enough flavor to make it exciting but not be overpowering. Sometimes people say bottled water tastes better than tap. So just kind of playing around with things. So for nausea, this can happen again from treatment itself, from constipation. If you're very constipated, that might cause you to feel nauseous. Severe pain can also cause some nausea. And then radiation to the brain or the GI tract sometimes can cause nausea. Click next. A lot of the same recommendations. Eating too large of a meal might make you feel too full or bloated, and then that can make nausea worse. So even if your appetite's there, but you're nauseous, having small frequent meals might be helpful. A lot of times people tell me that their nausea gets worse if they go too long without eating. So maybe you have something you tolerate well, like a saltine cracker or a Ritz cracker available, maybe when you wake up, when you have more of that bile in your stomach, to help just settle things so you don't get nauseous. So that might just take some trial and error, but avoiding going too long without eating can help manage nausea. Also, sometimes if you're nauseous, if you smell a food that is too strong, you might be really turned off to eating. So if you're not the one preparing the meal, sometimes it's helpful to not be in the same area or the kitchen where the food's being cooked. Of course, not always possible if you're the one preparing your own meals. But in that case, trying to pick things that don't have strong odor. So things that might be at room temperature or cold, like a turkey sandwich is going to have less odor than a hot turkey dinner. Something like that. So just things that just don't have very strong smells, so you don't smell it and get turned off before you even have a chance to take a bite of it. My go-to with managing nausea is breakfast foods tend to be really well tolerated. Pancakes, even frozen pancakes, they have some high protein ones now too, like Kodiak Cakes is a brand. So if you're nauseous and chicken sounds like it's not happening, trying to get like protein pancakes. That way it feels like a nice breakfast food, but you're still getting your benefit of protein. Or toast with peanut butter or a smoothie, things that are like chicken noodle soup, mashed potatoes, kind of comfort foods like that. Pasta dishes, also not strong smelling. And then again, if you need to use liquid calories and protein, that's also a good option for if you're nauseous. And then again, making sure your anti-nausea medications are optimized. Maybe you can alternate Zofran and Compazine to get benefits of both. Maybe they need to add on another medication as needed. So again, coming back to advocating to the team to just make sure you have what you need from a medication standpoint. Okay, next, please. Diarrhea could be from a side effect of chemo, depending on what drug you're on. Don't really see it as much with carbotaxol, but some of the other ones can. Radiation to the abdomen or pelvis, which might be common treatment for like an endometrial or cervical cancer, if you're getting whole pelvic radiation, where the bowels are also basically getting treated as part of the radiation. Diarrhea is very common starting, it's like happens 80% of the time, which is why I'm bringing it up, maybe 2 to 3 weeks in towards the end. If you're getting a full course of whole pelvic radiation, you might have surgery to the GI tract where things are different after, and that might cause diarrhea, or if there's cancer located in or near your GI tract. So these are just some reasons diarrhea can happen. You can click next. So again, small frequent meals, sometimes greasy or fried food can worsen diarrhea. And this also might be a time I might say to try to limit caffeine. If you notice that caffeine kind of like stimulates your bowels, if it doesn't, continue to drink it, that's fine. This is also where a low fiber diet is really helpful. Those foods that are high in fiber, like cruciferous vegetables, whole grains, those add bulk. And sometimes if you're having diarrhea, if the GI tract is irritated, those might make for, eating those foods might make for more frequent or uncomfortable bowel movements. Again, you might have to see, you might eat those without a problem, or your diarrhea is like, diarrhea happens whether I eat a salad or if I eat toast. Then there's really no point in limiting your diet. You might as well eat what you like if it's not affected by food. So just seeing, I know when I eat this and this and this, I'm fine. If I eat this, I have worsening diarrhea. So just keeping an eye on things like that. Sugar alcohols like sorbitol, mannitol, xylitol, which are often in like sugar-free products, those tend to cause diarrhea for some people, even normally if they're not having diarrhea. So if you're having diarrhea and you are eating sugar-free items, just check the label to see if there's any of these sugar alcohols in there. You might want to hold off on those products when you're having diarrhea. Unless instructed by your team, it's helpful to drink electrolyte containing fluids when you are having diarrhea because you have a lot of losses. Like if you've seen the products called like Liquid IV, that's one of my favorite ones. It comes in like a powder packet that you can add to a bottle of water. It's called like a hydration multiplier. So 1 bottle is equivalent to drinking 3 bottles. It just helps optimize your hydration. Also things like Drip Drop, DRIP is a good product. Noon tablets or Pedialyte all work. So talk to your doctor if they think that would be a good option for you. If you have, again, this is super specific, but if you have kidney dysfunction, maybe they wouldn't want you drinking something with electrolytes in it, but speak to your doctor. But typically if you're having a higher volume diarrhea, it's great to replenish some of those electrolytes through your fluid. And if you are finding that you can't keep up with your hydration, call your team because they might be able to bring you in for some IV fluids if you need. And again, speak to your doctor about diarrhea. They might recommend some anti-diarrheal medications like Imodium or something prescribed, I always defer to the doctor for that, because even though it's over the counter, we kind of treat it like a medication, just making sure it's safe for you to take. Okay, click next. So here's kind of what we were getting to before with like the metabolic approach and the keto diet. So the first part goes through what I had already mentioned about how glucose fuels all the cells in our body, and research shows that tumor cells have many metabolic pathways. They can use fat and protein and other pathways for growth. And right now there's not evidence to support reducing intake during treatment at this time. These are just a few studies that I found that specifically looked at ovarian and endometrial cancer with the ketogenic diet. And I should go back and discuss what the keto diet is if you're not familiar. So the keto diet is basically an extremely low carb, low sugar diet, sometimes less than 20 grams per day, and people might monitor their ketones using their urine to make sure they're in ketosis. Okay, so these are just 3 studies. Again, this is not a whole lit review of all the studies, so I just want to let you know that I just picked out some ones that were interesting in terms of different outcomes that they were looking at. These are all as of at least 2017, 2018, so they are recent. So the first study looked at safety and adherence to the keto diet in people with ovarian or endometrial cancer. And they found that at 12 weeks duration, so after 12 weeks of following the keto diet, it may be safe and achievable. Their compliance was 57 to 80%, and showed no significant difference in lipid levels. And the reason I looked at this is because the keto diet tends to be high in fat, because when you take out carbs, the only 2 other macronutrients left are protein and fat. So those have to go up if the carbs are going down. So if you're eating more fat and meat, people might think your cholesterol might go up. So this study showed that there wasn't a difference in lipid levels. Again, the study was only 12 weeks, so we need to evaluate longer term, but that's what this study showed. A different study with patients with ovarian or endometrial cancer found that it does not negatively affect quality of life and may improve energy, physical function, and diminish food cravings for starchy and fast food. So I thought that was interesting. Again, they also looked at it over a 12-week period. And then a third study in women with ovarian or endometrial cancer showed that the keto diet resulted in a selective loss of fat mass while retaining lean mass, so that's important, your muscle, and visceral fat, which is fat around the organs, and that fasting insulin levels were also reduced by following a keto diet for 12 weeks. So what this tells me is that, first of all, obviously we want to know beyond 12 weeks, but that's just what the studies looked at. So they're saying it's safe and feasible to do, but I didn't find any studies that looked at or that showed an effect in terms of cancer survivorship or reduced risk of recurrence. So I just want to make that clear that these studies didn't look at that. They were looking at these other factors: adherence, safety, lipid levels, loss of fat mass, insulin levels. Okay. So we don't recommend the keto diet as a standard of care. However, it's not harmful. And again, nutrition is a personal decision. I tend to recommend staying off of restrictive diets during treatment because of these potential side effects, because you might be having early fullness or constipation. But again, it's a personal decision. There are people that are able to maintain the diet while on treatment if they don't have significant side effects. But again, we don't recommend it as a standard of care, basically. And it's also always important to discuss with your doctor and your dietitian for individual considerations, maybe diabetes or something like that. Okay, you can click next. This is an interesting topic that's kind of up and coming. It's called short-term fasting. So it's not intermittent fasting. It's looking at fasting during or around chemo or cancer treatment. So right now, the literature is based on preclinical evidence, basically meaning not humans, rodents or primates, that shows that short-term fasting, which is STF, protects against toxicity of treatment, meaning side effects, while also enhancing the efficacy of chemo in various tumor types. You can imagine this is like new and exciting type of research. So potentially can, and I say potentially because this is preclinical evidence, enhance the effects of chemo while limiting the side effects. So in mice, it showed that tumor growth slowed with a 24 to 60 hour fast plus chemo compared to chemo by itself. And because lower glucose levels during fasting impose extra stress on tumor cells, and then the chemo would basically target those cells. So side effects included headache, dizziness, nausea, weakness, and weight loss. These mice lost a ton of weight during these trials. So is it safe in humans? The short-term fasting safe in humans? So basically right now, there's only a few small clinical studies evaluating short-term fasting combined with chemo. The first studies are basically looking at, is it safe and is it feasible? Which they show it is, but the studies don't have enough power to draw definite conclusions on these things that we saw in the preclinical studies, like will it protect against toxicity? Will it improve efficacy of chemo? A lot needs to be researched still. This is really new. So which tumors may this be effective in? It might only be effective in certain types of tumors. What is the optimal length of fasting? Obviously 24 hours is really long, but it's shorter than 60 hours. It's a really long time to fast. So what is the optimal length? Is it safe, right? They're also looking at if there can be a fast mimicking diet. So instead of actually fasting, maybe there's a diet that you can follow that has the same effects, but that still allows you to eat certain things. They're looking at that. How can compliance be increased? Obviously, this is extremely difficult to fast for this long. Another question is, do steroids like dexamethasone, which is associated, we take before treatment and a few days after, does that affect results? Because that can raise blood sugar. So does that affect the fasting state or does it not? So basically, there's a ton of questions right now about this. I did see that there's a planned trial of 150 patients, 120 with breast and 30 with ovarian. That is going to be the first randomized clinical study that compare short-term fasting to a fasting mimicking diet during chemo. It's going to look at not only quality of life, but it's also going to look at the histological tumor remission. So I think that said, it was recruiting from May 2017 to August 2020. So that might be something to look out for. In terms of take-home messages, it's too early in the research to recommend, short-term fasting for patients. We have had some people that have tried it. They have been pretty dehydrated and not feeling so great. It's just too early to tell. If you are considering trying this, again, right now, I would only recommend it as part of the clinical trial that looks at this. That's the only time I would recommend doing this, but it's really important to talk to your doctor. Okay. Also, the study showed that patients with malnutrition, weight loss, sarcopenia, which is muscle loss, and cachexia, which is like malnutrition, are not good candidates for short-term fasting intervention because the research shows for them they need more calories and more protein. So again, some really new, interesting research that's coming out that I would definitely stay tuned for. Hopefully things translate into humans. I know a lot of times things don't always go from preclinical to clinical and have the same effects, but it's definitely something I'm going to have my eye on in terms of kind of new nutrition topics. All right, click next. So nutrition answer after treatment on the bottom of the slide has the recommendations per the American Institute for Cancer Research. I just want to make sure that, it's not a one size fits all. So increasing fruits and vegetables, again, maybe if you tolerate low fiber better, you might have to cook them instead of eating them raw. That's fine. You may have a new anatomy after surgery or an ostomy that requires some modification to diet. That's okay. Maybe you're still dealing with diarrhea a few weeks after radiation and you need to hold off on implementing these recommendations. That's okay too. or if you have a partial bowel obstruction and you need to stay lower fiber because that's better tolerated for you. Or you may be on a PARP inhibitor that has side effects like nausea or decreased appetite or taste changes, where you still need to kind of use these interventions that we discussed earlier in the presentation. But in general, typically, American Institute for Cancer Research, these are the recommendations, which is being a healthy weight. You might have lost too much weight during treatment and have to get back up to a healthy weight. It's not always weight loss. So typically, if you are trying to lose weight, we recommend 1 to 2 pounds a week. That way you don't lose muscle. Okay, being physically active, eating a diet rich in whole grains, fruits, veggies, and beans. Again, modify where needed. Limiting fast foods and foods high in fat, added sugar, but again, everything in moderation. It's not super helpful to be very restrictive and having that cause so much stress. That kind of that's counter effects eating healthy, as if we're really stressed about it and worried about what we're going to eat all the time. Limiting consumption of red and processed meat. American Institute for Cancer Research recommends less than 18 ounces of red meat per week. And we consider red meat to be pork also. So beef, lamb, but also pork, just because of how it acts in the body. And limiting processed meats as much as possible. Limiting consumption of sugar sweetened beverages. Limiting alcohol. The recommendation for women is 1 drink per day, but if you don't drink that, don't go up to that amount. And then not using supplements for cancer prevention. I'm going to talk about supplements on the next slide. But again, this is just the in general AICR survivorship nutrition recommendations for once treatment is and its side effects are resolved. Okay, we'll go to the next one. I think this is the last slide. So supplements, super common that supplements come up. Right now, there's no evidence to support that taking a supplement decreases your cancer risk or for recurrence or cures cancer. Nutrients tend to be better absorbed when we eat them in their whole food form. So vitamin C works better in like an orange or a red pepper than when we isolate it and take it out and put it in a pill. Of course, there's some times when vitamin supplementation is necessary if you're deficient in something, or you had a surgery that affects the area where a nutrient is absorbed and you need to take a supplement for that, or you have osteopenia or osteoporosis and your doctor recommends you take vitamin D, or you're a vegan and you don't eat any B12 because it's only found in animal products, so you take a B12 supplement. Those are all extremely appropriate reasons to take supplements. But we're talking about, there's not a supplement that's recommended to like reduce risk or cure cancer, basically. Also, less is more. Some supplements may be harmful. So, for example, it's recommended to avoid high dose antioxidant supplementation during chemotherapy and during radiation because of potential interactions. But again, we don't recommend limiting antioxidant rich sources of food. Okay. So if you are going to take a supplement of any kind, it's helpful to buy one that has this USP verified stamp on. Supplements aren't regulated by the FDA, so they only come off the market if there is an issue. They aren't tested beforehand. But this USP verified shows that there's good manufacturing practices. What they say is on the label is actually what's in the supplement. They were made in like a sanitary environment and setting, and the dosage is correct. So if you are going to buy any type of vitamin or supplement, USP is good. The Nature Made brand is USP verified, and so is the Kirkland, like the Costco brand. So that's helpful. And again, before taking any supplement, it's good to talk to your doctor, pharmacist, dietitian, just because we kind of treat them like meds. Okay. And then I think the next slide is just some resources. And we can ask questions. I just want to make one point about the AICR.org website, the American Institute for Cancer Research. It doesn't look like there's a ton on there nutritionally if you just go to their website. but they have a very great search function. So you can type something like sugar into the search box on AICR.org, and it will pull up evidence-based research that is up to date, but in like a very nice, manageable, readable way. So that's a good one. Okay. Yeah, what questions?
Thank you so much, Allie. That
Of
was
course.
awesome and super. You answered so many questions I'm sure people have. But so this is for you guys to ask anything, and we went over a lot, so it's okay to ask again.
Yeah, that's a lot.
Diane, I think. See your
Yeah,
hand.
can you put up, Patrice, can you put up the last slide again so we can look at the resources?
Sure.
Yeah, any questions? I know I went over a ton of stuff. So happy to clarify anything.
So it's Amy again. I have another question about the evidence-based research regarding, nutrition and keto, et cetera. Once again, because the 3 studies you found wasn't regarding, effectiveness of a keto diet in terms of reducing the progression-free disease, et cetera. Does that mean, is there another resource that we could do some, are there places we can go look for
Yeah.
research, or have you determined there really hasn't been any research in that?
That's what I was looking for. And I couldn't find any. That's why I put those there. I like Google Scholar.
Okay.
And you can type in your keywords, and then sometimes it requires access to like a university like resource. Sometimes you can only see the abstract, but that's a great resource for, and you can filter by from this date on and type in your keywords. That's what search I did for this.
So Google Scholar.
Yep, Google Scholar, it's through Google, but it will only come up with like journal articles, studies, case reports, things like that. So it avoids kind of random things on the internet as opposed to doing like regular Google.
Right. And then my other question for you is regarding constipation. How do you feel about MAG7 versus Miralax? Because the concept of Miralax bringing in.
Open that. That's, do
Yeah.
not, please
there?
don't do that.
Oh, I think
Someone's
Hey,
not.
if somebody's not participating in
do
the
it.
conversation and talking to somebody else, we need you to mute.
so MAG is fine to use as a
They're
lab
expecting a full unopened bag from the school.
if you don't want to use Miralax. It's totally fine to use magnesium.
Yeah, I mean, the concept of the leaky gut, which as a nutritionist, you've probably heard of. And I was always worried about the Miralax bringing fluid in through your colon. Is that creating more leaky gut? Therefore, would MAG7 be better?
Sure, and that's totally fine. Also, sometimes with Miralax is if your hydration is not great, it doesn't work also. So
Okay.
Because it does rely on bringing, it's like you said, an osmotic laxative, it relies on bringing that fluid in. So that's fine unless someone's magnesium levels were super high, and that wouldn't be helpful, but I've truly never, really rarely ever seen magnesium too high. Usually it is too low. So
Okay.
yeah, and there is a type of magnesium called magnesium glycinate that if people need to take magnesium supplementation, but it too much causes them diarrhea, magnesium glycinate, GLYCINATE, sometimes allows them to go up on the dose without causing diarrhea. So because sometimes with magnesium, it's a fine balance between that. Yeah.
Okay.
Yes.
And what about probiotics? Are you a believer in that?
So probiotics, I always recommend the food source first, like anything fermented, yogurt, kefir, sauerkraut, kimchi, things like that. But yeah, it's totally fine. I did some research. I did a lit review on probiotics and radiation-induced diarrhea. And the research was mixed because it's really hard to interpret the studies because they all use different strains and different durations. So it was kind of hard, but again, not harmful. And PSL number 3 is a great one. Pricey, but good. Also, people like BioK Plus, which you can get in the supermarket in the refrigerated section.
Okay.
Yes, this is Shar. I had a question specifically about the surgical menopause symptoms. The hot flashes, fatigue, the mood.
Yeah.
What can help with that?
Yeah, great question. Unfortunately, there's not like a specific food. However, honestly, exercise helps mitigate a lot of the side effects, those type side effects. So like specifically like resistance exercise, like bands or body weight exercise or light weights 2 or 3 times a week can sometimes help with the hot flashes, help build muscle to fight some of that fatigue, help sometimes with changes in body composition that comes with like menopause, like surgically induced, and then also bone health. Doing resistance exercise will help support that. Sometimes people find that avoiding caffeine or very spicy foods might help with hot flashes, but again, I would just try that because if avoiding caffeine makes you unhappy and doesn't help with your hot flashes, then I wouldn't recommend avoiding it. But from what I've seen, it tends to be more exercise actually than food.
So
I'm very active. I walk, I use the rebounder.
Yeah.
I eat very healthy,
Mm-hmm.
sugars, no processed foods, but I'm still having trouble with that surgical menopause.
Yeah.
I didn't when I went through my natural menopause 20 years ago, but it's hitting hard this time.
Interesting.
Uh,
Yeah.
the endocrinologist that I saw last week said there's a medicine you can get at Natural Grocers called hot flashes. She told me that I should try that one. I haven't tried it yet though. It's worth the try because it's like it was unbearable this summer. I could not, I mean, in the winter it's easier because I can go outside and cool down and stand barefoot in the snow, but like the summer is horrendous. I definitely know how you feel.
Yeah.
Especially this past summer.
Yeah.
Kathleen's had her hand up.
Thank you. First of all, I just want to say this presentation was really excellent and so comprehensive. And I love that you are a nutritionist who works right in the GYN clinic. Just really well done.
Thank you so much.
Really, really well done. And boy, you covered everything. I was wondering at the very beginning of your presentation, I found it really interesting. You had a statistic, something about 70% of women who have ovarian cancer it wasn't malnourished, but what was that?
It
No,
was
it was.
malnutrition.
Malnutrition.
Yeah, at diagnosis.
They have what?
Malnutrition, it is.
At diagnosis.
It's a lot of the symptoms that come along with diagnosis, like fullness, low appetite, weight loss.
Okay, all right. That was very interesting.
Yeah.
And do you know where that was from?
So it's from, I have, it's called Oncology Nutrition and Practice. It's like kind of like our nutrition like book that we use for a diagnosis, but I can find the actual, so I put the book on there, but I can find the actual reference and send it to Patrice if you'd like.
Yeah, that was really good. And I'm just going to ask one more question, or I actually one more question, and then I just wanted to, let people know what I know about that surgical menopause. The question that I have is, are these slides going to be available to us?
Yeah, I don't see why not. I mean, we recorded it. I can send them in PDF form to you, Patrice.
That'll be great. That'll be great. And then just one thing that happened to me with the whole surgical menopause. My doctor, my primary care physician asked me about hot flashes, and I said, "Oh my God, I'm getting naked," and my husband is looking over at me like, "What the hell are you doing?" Because they were awful. And at the time, before being diagnosed with ovarian cancer, I was on an antidepressant. And what he did is he just upped my antidepressant, and the antidepressant that I'm on, and I think a few of them do, but it's called Effexor, and it has some kind of estrogen uptake thing. And it was really helpful. I have one hot flash a day at 9 o'clock. So,
Oh my gosh, 9
I don't know how
p.m.
people,
Is it at 9 p.m.? Because I have one at 9 p.m. every night.
I think it has to do, I honestly think it has to do with the Effexor is an extended release drug. And I think because I take it at 9 o'clock in the morning, I get one at 9 o'clock at night. So, but I do know some of the other antidepressants have an estrogen uptake, component as well. But again, excellent presentation. Thank you.
Thank you.
Brittany has her hand up.
Yeah. So similar to, I know someone had been asking about keto, and keto involves a lot of like eating lots of extra meat and cheese and stuff. And so I've also heard of and read about other studies where it's like the animal protein that could potentially be exacerbating IGF-1 levels. And some of even the diet books that like my oncologist hasn't given me specific dietary recommendations, but she's given me books that have been helpful. And some of them are actually interestingly like related to diabetes and like blood glucose and like having too many carbs, but also like the amount of, like, I know they say don't eat a bunch of red meat, but it seemed like there was also a correlation between just like any animal protein and IGF-1, which is insulin-like growth factor, potentially contributing to progression of disease. So I was just wondering what you know about that.
Yeah, that's interesting. I am not honestly so sure about like an amount that would increase IGF-1. I know intermittent fasting looks at some of that with reducing IGF-1 in terms of not specific like amounts or nutrition recommendations, but the intermittent fasting window of eating within 8 hours and fasting for 16 hours can show lower IGF-1. I'm not familiar with studies that relate it to progression-free survival or remission or things like that, but I know that that's some of the studies that look at intermittent fasting, look at glucose metabolism and lower IGF-1, but I'm not familiar with like certain animal proteins.
Okay. And what about just IGF-1 in general? Like, have you seen the studies that are like lower IGF-1 is correlated with lower incident of progression? Or
I haven't. I feel like a lot of the studies I've looked at just show that there's lower IGF-1, but haven't gone that next step to show that. Mm-hmm. Have you seen that in the books you've read? Where it relates
yeah, I mean, I've read about it. I've also looked at the Metabolic Approach to Cancer book, and I do have a naturopath, and we've talked about it. And she has a bunch of studies, and I've looked at it online, and it looks like there's like times in your life where, like, of course, like children, like having a higher IGF-1 is better because they need to grow. But as you age, you don't need to grow, and you shouldn't have an excess of that hormone. So things like milk and things that cause it to raise could be also causing your cancer cells to thrive. So I don't know. I mean, it's all, there's so much research. I feel like you could confirm or deny whatever you want online. So that's why I just wanted to ask like what you know or what you've heard about it. Because I have heard, even my oncologist mentioned like intermittent fasting might be like a good choice because dropping weight is good because fat has estrogen and whatever. So I was just wondering what you know about it.
Yeah, and that's definitely something to consider like post-treatment. I know there's been some studies with, and I don't cover breasts, but I looked into this a bit, so maybe don't quote me directly, but with IGF-1 looking at dairy for like estrogen positive, like hormone sensitive cancers. And there's been some research with dairy with looking at like bovine growth hormone and things like that, and milk
But from my understanding is that the studies don't really show a difference between regular milk and cows treated with growth hormones, and that dairy, there hasn't been shown a difference when people, in terms of like recurrence, if people do avoid dairy or not. But again, that's breast, so I don't want to extrapolate
Right.
data.
And then there's just like not a lot of research.
Yeah, there's not. And it's hard because like you said, you can kind of argue probably both sides of any of this. And I think there was a study with intermittent fasting with breast cancer patients from several years ago in the 2010s, but I forget which year, that showed lower risk of recurrence when people fasted for 13 hours overnight. So not really long, but just 13 hours. But I haven't seen that replicated, and it's been like at least 5 years. But again, if that's easy for someone to do, is to fast for 13 hours overnight, which might kind of be a lot of what people typically do based on when they eat dinner and when they eat breakfast, and of course not harmful to do. But again, that was with breast cancer patients. But thanks for bringing that up.
Yeah, thanks.
Jean?
Oh, looks like Jean has her hand up.
Oh, actually, I was just applauding and saying.
Oh, it looked like a clap, but I wasn't sure.
Very
I'm sorry. Somebody, Diane, Colin.
Okay, can someone clarify surgical menopause after natural menopause? I have never heard of that. And then after that, I have a comment that I would like to make, a suggestion. So can someone clarify surgical menopause after natural menopause?
Yeah, does someone who want to experience the difference comment on it? Because I'm not clear what the difference is.
I mean, I don't understand how you can have a surgical menopause after you've had natural menopause, because menopause is when the hormones stop working. If they've stopped working, you're not getting them.
I don't think it's at 0. So
I'm sorry?
I don't
So
think
I
it's
can-
at 0. So when you get them actually removed, there's a different level setting for some people.
Okay.
So I don't really understand and I know somebody else had mentioned having surgical menopause after menopause, but in my case, I was 47 years old and I was not in menopause. So I had what's called a surgical menopause. Does that
Yes.
make sense?
Yes. That's a normal, surgical menopause, I understand, but I've never heard of surgical menopause after natural menopause. And then my comment is, former spouse always said I had a 2-degree comfort range. And about 11 years ago, it dropped to 1 degree. I mean, I might get hot if I have a sweater on, and I would start to take it off and immediately get cold. And my GP, when I asked my GP, she just sort of shrugged her shoulders like, well, welcome to old age or something. And this is what you get to live with. And I did research online and I found out about iodine. So I take 1 drop of iodine at night before I go to bed, and I don't have that problem anymore. Iodine has something to do with controlling your body temperature. I don't have any idea if it would work for anyone else, but I found it works for me.
Interesting. I haven't heard of that.
Well, I had to find it myself. And I did
That's what I mean. You have to keep bringing these things up.
Yeah, I did this research like, oh gosh, 10 and a half years ago. And I just found it online somewhere, and I know I wasn't in Google Scholar. I was just doing regular controlling. When I was still working, I used Google Scholar all the time. And I actually forgot about it, Allie. So thank you for reminding me, because it's a great source, and everything they have, they are scientific articles. So they've been vetted, read, approved. So, they're factual.
Right.
So it's a great resource versus like, what is it? The one that everybody goes to, Wikipedia.
Yeah, with the articles in Google Scholar, you might have to like request access to a library or university or something like that if they're not fully there, but some of them are free full text, and oftentimes
at least you'll be able to see the abstract to know if you want to pursue getting the full article.
Yeah, and if you need an article that you can't access, then you can request it through a library.
Mhm.
And there may or may not be a fee. I know when I worked at the library, when we requested the articles that had to be paid for, it was paid for by the library, but we were a government library, so they were doing it for their work.
It can get pricey.
Yeah.
Well, I just want to thanks on behalf of everybody, Allie, for you making time to share with the community at large, to answer questions. And again, just thanks for our great partnership with you all. And we will continue, I'm sure, to lean on you guys when we can.